So for today, I'll first talk a bit about my own personal trajectory. So I actually will be talking mostly about pathology today, but actually did my PhD in radiology, computer-aided detection of prostate cancer using MRI images. And well, as some of the older people in the audience might still remember, that was the time when you would do handcrafted features and just try to cram as many features as you could into a machine learning model to try to do something meaningful with that. So that was essentially my entire PhD until the last year, where I visited Cleveland in the US, and I met Angel. Angel is, as far as I can still tell, the first person ever to apply convolutional neural networks to whole slide images in digital pathology. And I was very inspired by his work. So actually, I wanted to try that out as well. So the whole deep learning thing for us started relatively early. And actually, it was also quite a bit of a sad time because I spent a lot of time working on my PhD AI system to detect prostate cancer in MR images. I spent a full year on developing that system, and then I got an area under the curve of 0.83 roughly. And then I came back from Cleveland and started using deep convolutional neural networks. And within a couple of weeks, I had a system that was vastly outperforming the thing that I was working on for a year. But of course, initially a sad time, but also became more positive. So this was my thesis that I ended up after 4 years. And most of this was this handcrafted feature design. So I also realized very quickly that nobody should ever read my thesis, and it can just be useful for campfires. Luckily, I think the work I did after has a little bit more staying power. So yeah, for us, we started using deep neural networks for essentially every single task that our lab was working on, whether it was breast cancer in MRI images, whether it was lung nodules in CT, mammograms, white matter hyperintensities, and most of these publications were relatively early, and were really showcase of how quickly you could adapt with these newer machine learning methods to all kinds of different problems, as long as you had good high quality data. So it was also a fun time in the lab, because sort of I always think like this must have been how people felt in when CRISPR-Cas was discovered in genetics, right? So you have this new toolbox that suddenly makes stuff possible that wasn't feasible before. So after my PhD, I actually switched fields. So I went from radiology to pathology, and I checked the Institute's website a bit. I don't think there are many people working on pathology, so I decided to do a brief intermezzo on what clinical pathology is. So the formal definition of histopathology is the microscopic inspection of stained tissue section to detect and grade disease. And that's a lot of manual busy work. So typically you get a tissue from a surgery or a biopsy procedure. It's fixated, so it's embedded in formaldehyde to make sure that it preserves for a long time. It's solidified in candle wax, and then very thin slices are cut, roughly 3 to 4 microns. These cut tissue sections are stained, and I'll get back to that in a bit, and then inspected under a microscope by a pathologist. And if I talk to a general audience, I think most of you will know, if I talk to a general audience, the pathologist is typically the one who determines the cause of death in murder thriller police TV series. But actually, almost all diagnoses, especially in the oncological space, are eventually done by pathologists. They often provide the answer whether something is cancer or not. We'll briefly get back to the staining. So normally tissue has very little contrast, so we tend to stain it with dyes. And this is the most common one. This is a hematoxylin and eosin stain, where the hematoxylin is the stain that you also use for genes. So it's actually dark blue purple. And eosin is the pink stain, and that stains connective tissue, and the hematoxylin stains the nucleic acids in the cell nucleus. So all the cell nuclei become dark purple dots, and now the pink background is connective tissue and collagen. You can also stain for a lot of other things in histopathology. So if you're interested in iron, there's a specific stain that stains iron particles, or mucosal membranes. Sirius red stains specifically collagen fibers. So there's a lot of different aspects you can highlight in histopathology images depending on your diagnostic question. In addition, we also have targeted stains that can be used for targeting specific antibodies. So for example, Ki67 is a protein that plays a role in the cell cycle. So if you stain for that, you get cells that are in cell division, and that says something, for example, about the growth speed of cancers. So with pathology, we can actually collect a lot of different types of information from tissue. So what are challenges in pathology? Well, even though a biopsy might not sound big, but I'll show you that's actually very large amounts of tissue that we have to inspect. So this is, for example, a prostatectomy slice. Prostatectomy is a surgical removal of the prostate. They cut the prostate in these thin sections, and then you have to identify whether there is cancer cells present. Well, and if you look at low resolution, this is roughly how the whole prostate slice looks, but you can really zoom in up to the size of a single cell nucleus. So there's a lot of ground to cover when you want to inspect everything. Yeah, we have to combine different information from different stains. I already showed you that. And because we have to cover a lot of tissue, there's really no quantification in pathology. Because we traditionally use microscopes. So for example, if you want to count a specific type of cell, that's not really feasible under a microscope. So luckily, we've had a lot of innovation on the computing side, not just for developing AI methods or running AI methods, but also for improving the workflow in pathology. So the increase in computing power over the past decades, cheaper digital storage and high resolution small digital cameras have led to the introduction of whole slide imaging. So I would say in the Nordics and in the Netherlands, almost all pathology labs now are digital or use digital equipment. So they don't use microscopes for their day-to-day anymore. They just look at computer screens. Yeah, initially these devices looked a bit like this. So it's essentially a microscope with a camera on top. Nowadays, these devices have much larger capacity and scan thousands of slides per day, who are then inspected by the pathologist on computer screens. So what makes these images a bit special compared to other medical imaging modalities is that they are actually more comparable to topological data, so maps, than to typically medical images, because they are also stored in a multi-resolution fashion. So you can observe the entire section, for example, at low resolution, like you would a country in Google Maps, but you can also zoom in up to the level of an individual street, or in the case of pathology, up to an individual house. Which means that each image carries an enormous wealth of information. Okay, so that was the brief intro. I'll start with, so how do we then apply AI methods to this domain of pathology? Start with a brief example that we worked on the first, because we always heard from our pathologists that this was the most annoying task they had to do in the hospital. And this first project was about lymph node metastases. So I think most of you will know what lymph nodes are, but they play a role in your immune system. And in most cancers, these are lymph nodes are the most common site of initial metastases. So if a cancer metastasizes, this often goes via the lymphatic vessels, and then cancer cells end up in lymph nodes where they get stuck and they start growing, where you would get a metastases. So often the diagnostic question for patients who come in with, for example, a breast cancer is the cancer still only localized in the breast? Because if yes, then removing the lesion from the breast is curative, right? So then you have removed all the cancer from the body. However, if the cancer has metastasized to the lymph nodes, then just removing it in the breast will not be curative anymore, and you need more systemic treatment. So either radiotherapy of the affected lymph nodes, or chemotherapy, for example. So how is this diagnosis typically done? So for example, in breast cancer, the lymph nodes in the armpit are removed and then processed by a pathology lab, and then the pathologist inspects these lymph nodes under the microscope for the presence of tumor cells. And the reason that this was ideally suited for AI is because pathologists always describe this as looking for a needle in a haystack. I actually have a small movie to show to sort of drive this home. So this is a resected lymph node. You see different pieces of tissue. These are all from the same lymph node. And if a pathologist has to inspect this lymph node for the presence of metastatic cells, this is how they have to do it. So they have to go over all these cells, try to find the atypical cells, try to identify the cancer cells. And well, this is a single lymph node. You can imagine if you have multiple lymph nodes, there's even more and more work. So we always felt that this is something that's ideally suited for AI, because it's not a mentally challenging task. When a pathologist would see cancer cells, they would recognize them, but it's just a searching task. So it's something that's relatively easy to automate. So just to show you, in this case, this is the entire metastasis. So this is what the pathologist would have had to find in this setting. So you can imagine that it's quite time consuming. So this was, like I said, the first project we worked on with deep convolutional neural networks. I think everybody in the audience here will know how it works. So back then we were just using convolutional neural networks. We would take examples of tumor cells, examples of normal cells. We would put that in a deep neural network that we would train to predict whether something is normal or a tumor. And then with some annotations by a pathologist, you could evaluate whether it was doing a good job by applying it, of course, to unseen data. So that was not part of the training set. For example, in this case, you can see that it very nicely localized the metastases, and that it would have actually been much quicker for a pathologist to just only look at the red highlighted area than to have to inspect the entire lymph node. So we're quite excited, but I think we generally do research with the perspective of with the perspective that the chance that we as a research group of say 20 to 30 people come up with the best possible solution to solve a problem is pretty small. There are probably other people in the world who are smarter or know better solutions than we do. So the way we typically approach science is when we have such a paper published, we make all our data available, and then we ask the world, the community, to come up with better solutions than our solution. And we do this through the concept we call medical imaging challenges. So in 2016 and 2017, we organized the Chameleon Challenge, which stands for Cancer Metastases in Lymph Nodes, where we made all our data available and asked the community to come up with a better metastasis detection algorithm than ours. Just for some perspective, so initially in Chameleon 16, we made 400 slides available. In 17, we made 1,000 additional slides available, 1,400 slides, images. That doesn't sound like a lot, but actually because these images are so big, it was more than 3 terabytes of data. So actually quite complicated to share with the world in 2016. And we actually had a lot of participants for these challenges. I show here the top 5 from those challenges, which was Harvard Medical School and the lab, MIT and the lab in China. And we actually compared the performance of these algorithms to the performance of pathologists in clinical practice. And those are all the red dots. And then we also had a pathologist who we said, okay, you have an entire weekend to go over the entire test set. You're not allowed to miss a single metastasis. So spend as much time as you want, which is not realistic of a clinical situation where they're under time pressure and have to look at many, many slides a day. So you see here that a pathologist who has unlimited time actually performs relatively well, very close to the top left of the ROC curve. But actually, the best algorithms were competitive with this pathologist and better than all the pathologists in clinical practice. And this was actually the first time that we could show that an AI model could outperform doctors or pathologists in pathology. So it was, for us at that time, a big deal, because up till then, we were always struggling to get as good as a doctor, but this was the first time that we could actually outperform them. And we'll see more of those examples later. So what did we learn from this challenge? Well, of course, that other groups did a better job than us in developing good models, but also that actually the most time-consuming part of all these AI projects, so if you have 1,400 slides, is the fact that we have to do all of these annotations. So you need good quality training data, which means that our poor pathologists have to spend a lot of time drawing all these outlines of the tumor cells so that we can train AI algorithms. Well, what you would actually want to do is just have a label for a lymph node, which might be metastases present, yes or no, and just feed in the entire image and then have the network figure that out. So that would save us a lot of time in annotations. But yeah, I already mentioned a single pathology slide is 2 to 3 gigabytes typically. And even with high-end GPUs and modern neural networks, it's impossible to fit that into the memory of a GPU. So yeah, this is what you would ideally like, right? So it would predict metastases, but if you would try this with whole slide images, after the first or second layer, you would immediately run out of memory. So this was never feasible, which is why we had to go through this patch-based approach where you took tiny examples and then have annotations done by a pathologist. So that was the case for a long time. A lot of our initial work focused on this patch-based approach with annotations, but we also developed a new approach that was published in IEEE Transactional Pattern Analysis and Machine Intelligence in 2021, which we called neural image compression, which is, I think, now the basis for most foundation models in pathology, where the idea was, okay, what if we separate this task of compressing the image into its relevant information and then subsequently doing the relevant clinical prediction. So here we have these patches who would have an encoder neural network that would embed the patch into a feature vector, and then we would stack the feature vectors so that they are still spatially coherent, and then do a separate convolutional neural network on top of this embedded image essentially, and then predict the clinical outcome. So we tried a lot of different things for encoders. So we did contrastive training, which I think currently is still the most popular. We did bigons, we did variational autoencoders to go to these feature vectors. And I think conceptually it was a very nice method, but if we actually tried it in practice, it was pretty bad. So I showed you the end-to-end patch-based approach performance, which had very high AUCs, close to 1. But when we tried this unsupervised approach with neural image compression, where we would separate the encoding and the prediction part, actually we couldn't get much better than AUCs of 0.7. Which, of course, made us sad because we're still stuck with making all these annotations and with these patch-based approaches. So we're obviously missing some piece of the puzzle. And that came later with a publication from the group of Max Welling, University of Amsterdam, where they developed a method that they called attention-based deep multiple instance learning. Was already actually published in 2018, but it took a while for the medical community to pick this up. And in that paper, they actually also showed on smaller images, so not whole slide images, how you could do attention-based multiple instance learning with whole slide images. So it essentially added an attention component to this architecture, which was not present here. So in our initial approach, there was no way for the neural network that had to do the final diagnostic classification to weight different areas of the image differently. So and then a group from Harvard, Faisal Mahmood's group, actually combined this idea of neural image compression with this idea of attention. And the way it works is actually pretty straightforward. So you still have this encoder network. So you take patch features, you have this encoder network that turns it into all these patches into feature vectors, so that you're certainly much more memory efficient, because you never need more memory than the memory you need for a single patch. And then they added an attention backbone, so that essentially weights the contribution of each individual patch to the final classification based on some attention weight that is learned. And what they showed is actually then if you could also visualize this attention, that this corresponds very nicely with the areas of the tumor cells. And they actually now had performance with this attention-based multiple instance learning that's comparable to doing this patch-based approach with hand-drawn annotations. So suddenly we were rid of this annotation bottleneck and could start applying this to much larger scale data sets, which became available because we don't have to annotate every single image. So we started applying that concept to a new domain or a new task. So I've been working on prostate cancer for a very long time, initially in radiology, then in pathology. And prostate cancer is one of those diseases where actually, even though a lot of men die because of prostate cancer, there's even many more men who have prostate cancer but die to other causes, because it's typically slow growing, not so aggressive cancer. So when a patient comes in with a suspicion for prostate cancer, typically at a certain point the biopsy is taken, which is then inspected, and then a pathologist doesn't just say is there cancer or not, but they assign a Gleason grade, which is a description of how normal do the cancer cells still look. So how much do they resemble the original benign tissue. And then, of course, with increasing Gleason grade, the less the cells still look like normal tissue. As you can see in Gleason 3, you can recognize the individual glands. In 4, you can see that they start fusing. And in 5, they're just replaced by just sheets and sheets of cells. And the idea here is that if you have just a Gleason 3 cancer, you might not immediately need treatment with all the associated morbidity. Whereas in Gleason 5, you need very rapid treatment and even systemic therapy potentially after the initial surgery. The challenge is that when pathologists have to decide on which grade they assign, you can already imagine that this is a very subjective task, right? So we make these categories as human, 3, 4, 5. But obviously, this is a continuous process. So most of the cancers will actually be somewhere in between these discrete categories. And that causes pathologists actually to differ quite significantly in their opinion. So this is an example from the Netherlands, and I'll explain this graph. So what they looked at is 36,000 patients or 35,000 patients in the Netherlands. They looked at, okay, what is the expected Gleason grade on average these patients should get. So on the y-axis you have the percentage of low-risk patients, which should be 35% nationwide. The confidence intervals differ based on how many patients a hospital sees, and all the dots are different hospitals in the Netherlands. And then you can see that if you are a prostate cancer patient and end up at this hospital, you have an a priori chance of getting a low-risk diagnosis of 20%. And if you go to this hospital, you have a low-risk diagnosis chance a priori of 40%, which cannot be explained by the differences in population. So the only way this can be explained is by differences in the doctors who do the diagnosis. And you can imagine this has significant impact on how we treat these patients. So we thought, okay, what can AI do? So we had AI for detection. Maybe we can also do AI for improved quantification, because the thing with Gleason grading is you have to make this assessment. Sometimes multiple patterns are present. So what is the relative ratio of these patterns and what is the overall grade that I assign to a patient? So we started initially doing this with a segmentation network based on annotations. And then we showed that you can very nicely quantify this exactly at the pixel level and then come up with a final grade assignment for a patient. And this system did a pretty good job. So we compared it against 14 pathologists from all over the world. Each of these light blue dots is a pathologist. We used Cohen's kappa to assess this agreement of the pathologist with the reference standard. The light blue dots are the inexperienced pathologists, and the dark blue dots are experienced subspecialized pathologists. You can already see as a patient you want a specialized pathologist. The median pathologist had a kappa value of 0.82, and the algorithm had a kappa value of 0.85. So again, we're pretty happy. We had something that was outperforming all the inexperienced pathologists and was roughly performing on par with the experienced pathologists. We published that, and actually what was the key takeaway from this paper was that there is only one AI model, but 1,200 patients, 6,000 biopsies, and 18 pathologists. So the AI model was the least important part of this study. And again, what we did is we came up with our own solution, decided this is probably not the best possible solution in the world. So we made all that data available, and together with Karolinska Institute and Google Health, we organized again a medical imaging competition, this time on Kaggle. So in total, we made almost 11,000 biopsies available for people to try to solve this problem better than us. And obviously, people were better than us. So this is the kappa value of the top 100 teams on the test set. If you remember, we had a kappa value of 0.85. So all the top 100 teams did a better job than we did, which was also good to see. We also validated these models on two additional external test sets that were not part of the initial challenge, just to assess generalizability. And we did that actually by having the participants send us Docker containers with their algorithms, so that we actually did the evaluation and not they themselves. And then we compared that to, again, pathologists. But on the left side, I have first the performance of the individual algorithms. So on the top, you have the top 15 algorithms on the challenge data set. That's the top graph. So you can see they have around 0.95 kappa. And you do see a drop in terms of performance on the external test set. So there is still some generalization gap between the different data sets, but almost all the algorithms except one generalized actually pretty well to unseen data. We also compared these algorithms to general pathologists, and we could show that both in the US cohort and in the European cohort, these algorithms outperformed the pathologists that participated. So again, we went from initial detection to a task where we thought, okay, I can definitely do this better, to a task where we do quantification, where we can also show that AI actually did it better than the physicians. But then what we also often do, because we are in a hospital, we have easy access to pathologists. So we want to validate, okay, what happens when we actually put these algorithms into the hand of the pathologist. So we actually had a study where we had pathologists doing first the Gleason grading without AI support. And then after 3 months, they had to redo it with AI support. This is how the interface looked for them. So this was with our own model. And we showed that in this cohort, the unassisted performance was a kappa of 0.8. And with AI assistance, they improved to a kappa of 0.87. But what's for us more important is not so much that they got a higher performance, but mainly that the inter-observer variability, so the standard deviation on the grading, got significantly smaller. So for a patient, that means that your diagnosis becomes more coherent and less dependent on the individual pathologist that is looking at your biopsy. So I think for us, these were all very nice results, but we could only ever do this work because we have access to lots of data. So in the previous example, we had 11,000 biopsies available, and that means we could never really apply this to problems or challenges, for example, rare cancers. So prostate cancer, of course, is one of the more common cancers. We could never apply this to more rare cancers or rarer diseases. But luckily, that's something that has changed over the past 2 to 3 years with the advent of foundation models. Well, that's something that many of you will know about. So we have foundation models in computer vision. But we actually also have a lot of foundation models in pathology. And the reason that we see this also a lot in pathology is that the domains of pathology and general computer vision are very similar in type of model architecture that you use. It's both 2D in contrast to radiology, which is often 3D. It's color images, RGB images. So a lot of these techniques that were developed in computer vision are very easily translatable to the pathology domain. I mentioned foundation models. So these are some of the foundation models that are now available in pathology. I could easily have made 3 slides now with this, because every week there's a new foundation model in pathology that you can use for applying to downstream tasks. And what has this enabled for us? So these foundation models are trained on in an unsupervised way on large data sets of pathology samples. And what they show that using these foundation models, you cannot just do well in detection of common cancers like breast and prostate, like what I showed you before. Here they have AUCs of 0.98. But if you use foundation models, you can also, if you have much smaller data sets, for example, on liver cancer or stomach cancer, you can get very competitive performances, because if you train on these small data sets with a model that has already learned to recognize what a cell is, what a gland is, that understands, quote unquote, understands pathology, you can suddenly open up a much wider avenue of problems that you can apply your deep neural networks to. So that's a bit where we are now. So I'd like to spend the last, let's say, 15 minutes of the talk talking about where I think it will be going. And that consists of sort of 3 trajectories or 3 roads that I see. So I think what we'll see in medicine is that we will move away from using the humans as a reference standard, because in many problems now we are just doing better than doctors. So then using them as reference standards becomes complicated, because how can you then still prove that you are better? I think what you'll see is a move away from unimodal pathology models, for example, to multimodal medical models, and from more narrow to broad AI. And I think that the last one is kind of, that's what you also see in other domains. I'll first talk a bit about the human capabilities and what type of work we do on that. So I talked about Gleason grading. So Gleason grading essentially for a patient is just a system to help patient prognosis and treatment planning, right? So if you have high Gleason grades or low Gleason grades, determines what kind of treatment you get. And we always worked through replicating the Gleason grading system, because we thought, okay, the pathologists know best what to look at. But we now also realize that there might be information that the pathologists are not taking into account, because it's very difficult for them to visually assess. So we said, okay, what now if we don't first replicate this human grading system, but we directly train AI models on tissue images to predict patient outcome? So that's exactly what we did. So we took tissue images from patients and had AI models directly predict the years to progression, so the years until the disease further develops. And actually that worked initially already very well. So we had 2 cohorts for this from Johns Hopkins and NYU. And just training a model to categorize patients and patients that progress quickly and that progress slowly showed very nice that we could separate those with AI methods, and that both that the AI score you get was actually additional to what humans were already doing. So even if we would take into account already things like Gleason grade, then still AI provided extra discriminative performance in separating these 2 groups. Well, you already certainly probably feel what's coming, right? So we built this own method, but then we decided, okay, probably other people can come up with better solutions. So we organized another competition around this, where we made available data from 4 different hospitals, among which is our own, in total almost 2,500 patients. And we asked sort of the community to come up with a system that could predict whether a patient would have a recurrence, so the cancer would come back after initial therapy within 5 years, and also the time in years until this event of recurrence was identified. And we also compared that to what the pathologists were doing. So pathologists do Gleason grading to do this prediction, and they do a pretty decent job. So if you just look at predicting whether a patient gets recurrence just based on their microscopic presentation of cancer, I think it's actually pretty cool that humans can do that. You can see that they have C indexes, which is a bit similar to interpret as an AUC of around 0.7, which is not bad. And that actually our AI algorithms performed roughly at the same level, depending a bit on the cohort. They were slightly better or slightly worse. And then if you would combine both the algorithm and the pathologist, you would get a better performance. So roughly a couple of percent increase, which was statistically significant. So that means that the algorithms were looking at something that the pathologists were not yet looking at. And obviously then, especially the pathologists are interested in, okay, what is it then these algorithms are looking at that we are missing? So we also try a bit to make that insightful in our group with the work we do for pathologists. And I talked about these attention maps before, which I actually think are not super useful because in many domains, you see an area highlighted, but you don't know what in this area is then relevant for the prediction of the algorithm. So if you would ask 10 pathologists, okay, why do you think this is red? You would get 9 different answers. So we went a different route. So we went with automatic concept-based explanations, where we took small examples of images and then extracted the feature embeddings from this network for these patches, and then clustered these features based on the embedding. And then we sorted them based on the prediction on whether this patient would recur quickly or slowly. And then you can make these types of figures. So these are all clusters that are associated with quick time to recurrence, so a bad outcome for the patient. And the bottom row is clusters that are associated with better outcome for the patients. And of course, we only show a couple of images here, but you could show many more. And that's just for us a way to communicate to pathologists, hey, this is what this model, these patterns is what the model finds relevant to discriminate between these two groups. And this is actually paper, not our own work. This is work from Google, but this is, I think, a very nice example how you can take those types of concepts and then actually improve the work of pathologists. So what they did is in colorectal cancer, they took the top concept, so the top row from this, and actually taught pathologists how to score that with 1, 2, 3 in terms of severity. So how present was this concept in the image? And then they showed that this AI discovered feature, if it's scored by pathologists, also still has prognostic power. So you could really use AI to discover a prognostic biomarker that you could then teach to humans, which allowed them to improve their diagnostic performance. So I thought this was a very nice sort of closing of the loop, where initially we were using humans to train AI systems and now AI systems to train humans. So I thought that was a nice result. I actually wish that we had written that paper. Now, of course, we're still working on this and extending this. So this was work that one of my students presented at the MECAI conference a couple of weeks ago in South Korea. We're actually attaching these concepts to a large language model, which can then also explain these concepts in medical text. And the way it works is you just look at the text embeddings of pathology text. You sort of close the distance between the patches and the text in latent space, and then you have clusters. You can actually, for each patch, sample a piece of text that would describe that patch, and then you can make sort of histograms, which of these terminologies would occur a lot, and that you can also then communicate to pathologists. Okay, so that's one aspect, going beyond human capabilities. We're doing those types of studies in many different diseases now. I think the next step is from narrow to broad AI. Well, I think this is sort of logical where this is going, but in medicine you have thousands of diseases, some common, some rare, and the current strategy is, if you look at the algorithms that are available in the clinic, is that for each disease, for each sub-question in a disease, we're developing a new AI model. And there are two issues with that. A is that doesn't scale, right? So you will never do it for every question that a clinician has. And B, for many cases, you cannot even collect enough data to actually train these task-specific models. So we need to move to models that can do more tasks in a single model. I think everybody's familiar with large language models and ChatGPT that you can ask to write a poem, which it does, usually not very good, but it does it when you ask it. And you can also use it to summarize text or explain scientific papers to you, also with, of course, varying performance. But the fact that you can do all of these things in a single model, that's, I think, something that you will also see more in the medical domain. I already mentioned foundation models in pathology. So there are a lot, and I did already mention that they actually allowed us to do a better job on, for example, rare cancers or questions where we actually have very little data. They can benefit from their unsupervised pre-training. But if you compare the current foundation models that are out there, and you would compare them to these narrow task-specific models, right? So this was the pathologist performance for Gleason grading. If I would then take a foundation model and ask it to do the same thing, for example, with linear probing, you would get a kappa of 0.75, which is not bad at all. But as you remember, the best task-specific models that came out of this challenge had kappas of 0.93. So there's still this big gap in terms of performance between the broad AI models and the narrow AI models. So that's, I think, something that we still need to address. And I think one of the key reasons, this is a very nice publication from Diagnostics, as a company in Germany, where they showed that most of these foundation models, at least in pathology, are not robust, do actually generalize very poorly to data from different medical centers. And what they actually showed is, if you take the feature space of these foundation models and you look at how much of that feature space is used to encode elements that are relevant for center. So if you want to classify which center a feature vector comes from, versus classifying which tissue a feature vector comes from, where you would say the tissue is relevant, the center is not relevant, it should work regardless of center, that there was only one model that actually encoded more tissue-specific information in its feature vectors than center-specific information. So all of these models here on the left actually use the majority of their feature space to encode center differences, which means that they are also very sensitive to center differences. But I think that's at least part of the aspect why foundation models don't really work yet so well as task-specific models. And another company in the pathology space sort of highlighted this further. So they looked at, okay, if we would then, for example, add tiny bits of noise to the images, and we would check how similar the feature vectors would stay, right? So you would imagine that if you have a high quality feature vector, that adding a tiny bit of noise to an image should not affect the feature vector too much. Well, that's very much not true. We can see here very clearly that it does have a big impact. Yeah, so that's essentially caused by this idea where you do the encoder separately, which is what you do in foundation models that can focus too much on irrelevant details. Okay, the last one is about going from unimodal to multimodal. So this is also not a new idea, but the general concept is that we now look as a community working on medical imaging too much at an individual point in the patient journey. But if you look at the entire patient journey, and I take the example of prostate cancer here, so they initially come in, usually they first get some form of blood test. Obviously, you can do some AI based on these clinical parameters if you want to. Then often an MRI is taken, where already AI is applied, biopsies, where you do Gleason grading. You can apply AI. Some of these patients will go into active surveillance, which means more MRIs, more AI. Some will get focal therapy, which is typically image guided, so more AI. Some of them will get surgery. I already feel it coming. Some will get additional radiotherapy. A subset of those patients will, after initial treatment, still develop metastases, which means further imaging, which often means some form of genomic testing at a certain point, or molecular testing, which might mean different types of chemo. or lutetium PSMA therapy in terms of prostate cancer. So if you look at this trajectory for a single patient, there's so much data for each patient that you should actually be able, in a domain where you, for example, have the biopsy or trying to answer questions from the biopsy, should be able to leverage information you already have from the MRI. Same post-surgery, you have all this trajectory, all this data from the patient that you have already collected that should help you make better decisions or get better answers further in the trajectory of the patient. The added advantages is that for many of the questions you want to answer on the right side of this graph is you will have very little data, because essentially if you go to the end stage of a patient journey, every journey is n is 1, because all patients will have a slightly different journey. But if you can leverage earlier data, you might be able to answer better questions. So this is not a new idea that you can use all this data. So this is a publication from Google from last year, where they introduced their MedPal multimodal architecture, where they say, okay, we can take all this information from a patient and then answer all these types of different questions. But I think this general concept as they presented is a bit flawed, because they operate from this idea that we have encoders for every different modality, and these encoders are frozen, so they never change anymore. And I always compare it with how we would treat our clinicians. We don't train them and then freeze them and then have them never learn anymore. Usually our clinicians operate in teams and they learn from each other. If our radiologist takes a lot of negative biopsies, the pathologist will tell them, and then they can adjust the way they read their MRIs to get better results. So we have doctors that actually influence each other, and I think these encoders should also be able to influence each other. So I think there is still some room for work there. So wrapping up, the way that I envision this is a bit like this. So, and this is more complicated because you need paired data from patients, which is difficult for a lot of people to gather. But you would have different encoders for each of the modalities, some form of mixing layer, and then you would do some relevant prediction, like whether metastases would be present or not. But you would actually optimize both these encoders at the same time, such that they can actually learn from each other's data. The reason that I typically use radiology and pathology is because that's an easy way to connect the ex vivo and the in vivo worlds, where in the in vivo world you can collect data about the patient as they are living, as the disease exists in their body. And ex vivo, you can get genetics and different type of molecular testing. For prostate cancer specifically, I think we can do something even cooler, because we actually take out the entire organ during initial treatment. So we should be able to spatially match those two samples. I'll explain a bit how we intend to do that. So this is how typically a prostate ends up in the pathology department. So you get out an entire organ, but then suddenly it's cut into all these small pieces to fit you on microscope slides. We developed a method that can then reconstruct the 3D volume, and then we can put that 3D volume back into the MRI. Let's show you how that looks a bit. We actually validated that method with removed prostates that were scanned in an animal scanner, and this is a bit how it looks. So this is a surgically removed prostate scanned at almost 12 Tesla in an animal scanner. So you can see very nicely a lot of detail. And then you can compare that very well with the actual pathology. So this is a step that we are taking now. If you're interested in this whole domain of multimodal medical AI, my students recently wrote a review on this. It's probably one of the last reviews that's ever written by a human and not by a large language model. So that's also, I think, maybe exciting. Yeah, wrapping up. So just as a take-home message, I think what our field would most benefit from is if people don't sit on their data and think mine, but actually, like we do in our challenges, make all the data public. So why would you want to do challenges? It opens up data for others. It rapidly improves the state of the art, independent validation. Well, obviously might get you into nature medicine, but that should not be a reason to do it by itself. But also because it's a lot of fun to organize these types of challenges. So if you're interested in working on this type of data yourself, we have 2 challenges for which the data is available now. So one is Chimera, that's on multimodal AI, where we have prostate MRI and prostate H&E. And for bladder cancer, we have paired H&E and RNA data. And we also ran the Unicorn Challenge this year, which was on foundation model benchmarking, vision and language tasks. So if you have an interest in that, you can also have a look. I'd like to acknowledge all the people who do all the hard work and allow me to take credit for it.